trained at some of the nation's most respected institutions, including Case Western Reserve University, Massachusetts General Hospital, UNC, and Wake Forest, where she also earned a Master of Science focused on cardio-oncology. Her clinical and research expertise places her at the forefront of a field that is becoming increasingly vital as cancer survival rates improve. Dr. Branch has not only advanced this specialty through research and national presentations, but has also led the development of a dedicated cardio-oncology program and is now bringing that expertise to underserved communities in Western Kentucky. Her work reflects a deep commitment to health equity, community engagement, and patient-centered care. Today, we'll explore her journey, the future of cardio-oncology, and how innovation and access can reshape patient outcomes everywhere. Now, Dr. Branch, I have a little disclaimer to read for you. The views and information shared by Dr. Mary Branch in this episode are for educational and informational purposes only and should not be considered medical advice. This content is not intended to diagnose, treat, cure, or prevent any medical condition. Listeners should consult their own physician or qualified healthcare provider for personalized medical advice and care. Dr. Branch, it is an honor to have you with us. Welcome to CyberConnect.
Thank you. Thank you for inviting me. I'm looking forward to the conversation.
Thank you. Dr. Branch, you've had an impressive journey from Youngstown, Ohio, to becoming a leader in cardio-oncology. What inspired you to pursue cardiology and eventually specialize in this emerging field?
So, yes, I'm from Youngstown. I was fortunate enough to have a parent in medicine. So my mom is an infectious disease specialist, and she was practicing in Youngstown, where I grew up. And one year when I was in college, she knew I had some interest in medicine, and so she decided to ask some of her colleagues to let me shadow them. So I shadowed her, infectious disease specialist. I shadowed a psychiatrist. I shadowed, different specialties, and I shadowed a cardiologist. So when I met the cardiologist, just clicked for me. We were doing stress tests. I was watching him put in pacemakers. He was in the cath lab. And I was just blown away at the multifaceted role that this person had, and also the high energy of everything that they were doing. And furthermore, when they were doing a cath, which is where you put a stent into an artery for someone who's having a heart attack, they were saving someone's life within 15 minutes. So for me, I was just blown away at the depth of the field, how interesting it was, how versatile it was. And I knew that fit and matched my personality and my sort of energy level and enthusiasm. And it was almost like a sign, because at the same time, a film came out called Something the Lord Made. And it was a film on HBO. And the film was about Dr. Vivian Thomas, and he was a researcher at Vanderbilt, and also he went to Johns Hopkins. And so he was African-American gentleman. This was in the 1940s. And he was initially working in the lab, sort of custodial work, but then showed that he was very brilliant and able to contribute to the research. And so he helped come up with a treatment for a congenital heart disease called tetralogy of Fallot. And so within that story, something told me that I would have a similar journey if I was interested in cardiology, that similarly I would come up with certain barriers, whether it be related to race or gender, and that watching him, that was almost like a guide for me of what I would need to know to get to that point, to get to cardiology. So these two things happened at the same time, the shadowing experience as well as the film. And I just said, this is what I want to do. This is what excites me. I was very passionate about it. And I decided I wanted to be a cardiologist.
Oh, this is outstanding.
Yeah.
That's a good motivational way to start something with passion.
Right. Passion is really important. I think you have to love what you do because, again, there's going to be a lot of obstacles. And as we know in any relationship, and that's what your career is, that there's going to be a lot of challenges. And so I knew I really had to love it, and I had to be 110% sure that that's what I wanted to do.
Wonderful. You trained at institutions like Case Western, Massachusetts General Hospital, UNC, and Wake Forest. How did these experiences shape your clinical and research perspective?
Yeah. So in terms of Mass General, I only and after college, I wanted to boost my resume. And so, because I was taking the MCAT and I wasn't a test taker. And so I wanted to do something in between college and applying to medical school that would help boost my resume and I would get another opportunity to take the MCAT. So a friend of mine said, "Why don't you try to apply at Mass General Hospital?" I ended up getting the role there and doing research. And, by engaging in research, by doing it every single day, when I retook my exam, I didn't second guess the questions. I didn't overthink the questions because I was doing the PCR, doing the biology. So in terms of research, that really helped with my test taking skills, that helped with just my research knowledge to be able to get to that next step to medical school. At Case Western, I was working with, I had classmates that were very brilliant. They went to many different institutions, and these were just very enthusiastic, very brilliant people. And so iron sharpens iron. So what I learned from Case is one, just being around people who were very diligent in terms of their work ethic, people who were very gregarious, people who were very kind and very optimistic. So I was learning how to be a leader at Case Western, and I was working with just the greatest minds and the greatest people. I think, I'm
Right.
biased, in the country, and that really helped me as a physician. Just being inspired by those folks, and then in terms of my training in North Carolina, North Carolina, they really work you. They work you very hard, and as we all know, North Carolina is the stroke belt. And so there are a lot of very complex patients that we saw here and there in Cleveland, but in North Carolina, it was almost every other patient was very complex, very complicated. So I learned how to manage a multitude of patients. Right? We were covering 40 patients by yourself, which was a lot compared to, when I was in the, Midwest. And, I learned more about one, being able to manage that, and then two, being able to provide my colleagues with contingency plans because I knew what it would be like on the other side. Furthermore, I learned more clinical skills and more procedural skills as well. And so, what I learned from that experience is it was one, how to manage very complex patients, a lot of patients, and also how to build up my procedural skills. So, so each experience helped shape me in different ways, and so I'm just very grateful for all of my training.
Wow, that's nice. That's a lot of different expertise there. Yeah, and I think UNC stands for University of North Carolina, correct?
Correct. Yeah, University of North Carolina, Chapel Hill. So I did my intern year in Pittsburgh actually at UPMC, but then I met someone and wanted to start a family, and so I ended up transferring to North Carolina so that I could start a family and continue my training. So
Right.
that was Chapel Hill. Hmm.
Nice. What drew you specifically to cardio oncology, and why is this field becoming increasingly important in modern medicine?
It's a great question. So, as you know, I was very passionate about cardiology, so I wasn't going to give that up. But when I was an intern in Pittsburgh, I was working in the cancer hospital. And I started to develop a passion for oncology. I liked the genetic component of it. And I also liked being able to work with families in the family meetings that we had when there was not much we could do, but it was just a time to talk with the families about their loved one and really helping them in that moment. As an intern, I was practicing during the opioid crisis. And so a lot of times, all we were really doing was trying to get people off of opioids. And so it was pretty disheartening,
Right.
traumatic. So when I was able to work with cancer patients, I felt like this is why I wanted to come into medicine. This is what I want to do. So I said, well, I don't like to compromise. I typically do not compromise. And so I started to Google cardiology, oncology, and I found that there was a field called cardio oncology. And I said, well, that's interesting. That sounds like that could fit me pretty well. So I started reading the New England Journal articles, the initial New England Journal articles of some of the, originals who looked at anthracyclines and breast cancer and looked at heart failure. And so then I started to read more and more and more of the literature. And so that kind of drew my passion in. And then I went to a conference. And at this conference, there were two women who were in charge of cardio oncology. And I didn't see many women in cardiology. And so I thought, okay, this really feels like a perfect fit for me because I had these two women to, look up to. It was a very warm and welcoming environment with the cardio oncologist, and that was it from there.
Wow. How's that field for women, especially women of color, in terms of cardio oncologists?
You said how is the field? Like how
Yeah,
welcoming
how's
is
that
it?
feel?
Or
What's the statistics in terms of people of women of color who are in that field? What is that a
in
great
cardio oncology?
right?
Yeah, not many. If we're just thinking about African American women, I can think of two that have been very passionate within the field research wise. Dr. Sherry Ann Brown. But that is about us. I think it's about mainly just the two of us.
Oh, wow,
So not not too many. But
wow,
again, it's a mix of folks, and like I said, they were very welcoming. And in cardiology in general, you're not going to find a lot of folks of color, African Americans, and certainly not a lot of African American females. It's probably less than 1% globally.
wow,
So, that wasn't something that was too, foreign to me because that's how the field is. And that's kind of how I grew up. I mean, I integrated my private school essentially. I was the first African American to graduate my
wow,
private school. It was a Jewish school, but it was a private school. So that's
right,
why my mom wanted me to go. So I learned Hebrew. I read from the Torah. But, it was great education. So it was something that I grew up with, that I understood. And I was also the first African American female to graduate from my cardiology fellowship as well.
wow.
So for
That's
me,
outstanding.
it's just become par for the course.
Right. Wow, that's great.
Mhm.
You mentioned opioid earlier. How does that affect cancer in patients or patients with heart problems?
Yeah, so opioids, in terms of cancer, if folks have cancer, typically we want to make sure that they are not in pain. And so in terms of abuse, that's not something we see too much because these people are end stage. So we're going to do whatever we need to do to help them. I didn't see a lot of kind of opioid abuse in that particular population. But in terms of heart disease, I don't see a lot of intersection with opioids and heart disease, thankfully. The sort of opioid crisis was a lot of times younger folks who unfortunately became addicted to it. But the cancer population was typically separate, and in terms of opioids for them, it was mainly pain relief from the cancer itself. And so typically we didn't see a lot of abuse on that side of things. But two different disease processes, both diseases and both problems, but they were separate entities.
Wow. And what role do demographics play in that category?
Yeah, so in Pittsburgh, it was predominantly Caucasian who succumbed to opioid abuse back when I was an intern in 2015 in Pittsburgh. They were typically working class folks who somehow got into using opioids and became addicted. And the thing is, to be honest, there were Black patients who would be in pain, African American patients in pain, or different processes that lead to a lot of pain, and they weren't always given pain medications. And
Right.
so they were almost spared from the opioid crisis because they weren't really introduced as much to opioids as the different demographics, which were the kind of working class Caucasian Americans. And so it was sort of a silver lining in that sense, at least for the African American population, is that there weren't many because of discrimination,
Hmm.
to be honest. And so, but it was very sad to see any human, succumb to opioids and to die from it because some of the people were their tolerance was so high for opioids that we couldn't even help them pass away
Right.
comfortably. And
Right.
so early in my training, there was one patient that they were extubating, and I had to hear him dying because they
Mm.
couldn't sedate him enough. So, it's once I saw that, it really didn't become anything else. It was just humanity, and that
Right.
that was hard.
Yeah. So comorbidity has a great deal to do with that too, besides the demographics.
Yeah, certainly, folks who have back pain who need the medications, they're gonna, tend to maybe be susceptible to needing more opioid medications, and that can put them at risk for opioid addiction.
Right.
So, our environment, the foods that we eat, obesity, and then those folks can get, you know, if they're working in an environment that could hurt their back, but they're already obese and their
Right.
joints that can hurt their joints. And so then they need pain medication. And so it's just sort of this vicious cycle. And then they were getting it, and there were no rules or regulations at that time. The
Right.
CDC didn't come out with anything until towards the end of my residency. So none of us had a guide, and it was COVID similar, but none
Right.
of us really had a guide on how to do this safely.
Right. For our
Yeah.
audience, can you explain what cardio-oncology is and why it's critical for cancer patients today?
Yes. So cardio-oncology, my passion, we're back to that. So cardio-oncology is a field of cardiologists who understand the effects of chemotherapy on the heart. So our goal is to help people continue with their chemotherapy and support whatever cardiac diseases that may come up during treatment. So, for example, with women with breast cancer, they're on therapies that can put them at risk for heart failure or arrhythmia. So our goal is to follow those patients closely, help manage them so that they, one, try to heart failure, and if they do go into it, continue to treat them and help support them through their cancer therapy if we can. Or if they have to pause cancer therapy, we treat them and then try to get them back on the horse. Because what the research shows is that older women with breast cancer are more likely to die from cardiovascular disease as opposed to the cancer. A lot of these chemotherapy agents are improving survival tremendously. However, we're still having challenges with cardiovascular disease mortality. Although we are doing better with heart attack related mortality, we still can do better as it relates cardiovascular disease leading to mortality. So cardio-oncology is really important because we meet people before they start their chemotherapy, and
Right.
we work with them throughout it, and we really work with the oncologist to say, hey, you can keep going, like don't give up on this person. We'll deal with their arrhythmia, if their heart function drops a little bit, if they're not clinical, if they don't have shortness of breath, if they're doing okay with it, we'll just put them on medicines and say keep going. But before cardio oncology, a lot of times oncologists would just, some may just stop the cancer therapy altogether because they didn't know the nuances of cardiology and were maybe afraid that they could hurt the person, so they would just stop the cancer therapy. But our goal is to don't give up on them, don't stop the therapy, and we're here at any moment. We're always reachable.
Right.
And we're here to say, hey, keep going, and this is what you can do to help with this person. So we're kind of a cheerleader as
Right.
well. And that's just the personalities of folks
Right.
within the field, and that's why I enjoy it.
Right. Yeah, with good reason. I would enjoy that too.
Yeah, because not many cardiologists are like that.
Right.
Yeah.
Mortality rate that you mentioned, does that have
Mhm.
anything to do with the cancer stage that a patient may be in, or does that have anything to do with chemotherapy or the stage level that could prove how effective a particular um, chemotherapy may be before mortality?
Absolutely.
Yeah.
Yes, absolutely. So if someone is presenting, let's say, with stage 4 cancer, then certainly their mortality rate is going to be a lot higher, whether it's due to the cancer itself or heart disease. It's hard to really tease out because if you're presenting that late, it's hard to really help prevent anything. And in terms of the cancer therapies, if you're stage 4 and it's metastatic, that can be very difficult to control. And you also will see, some disparities with that, some racial disparities where, African American women present with later stages of cancer. And that can be a challenge because we're a little bit late to the game in terms of trying to mitigate their cardiovascular disease risks. And also, and they're a little bit late in the game in terms of the chemotherapy that they can use, or if, They could do mastectomies. If it's metastatic, then it's a little bit late to try to remove the cancer and keep it in stage one. But if they're metastatic, you can't take out each tumor. And
Right.
so that can be much more challenging. And the therapies are good, but again, it just becomes more of a challenge than, let's say, stage zero or stage one.
Right.
Um, so.
Right. And I assume that the recovery rate might be a little bit way less at stage four than any earlier stage, right?
Right. Yeah. Because stage four, like I said, if it's metastatic, who knows what other organs it might be affecting. And then some of the cancer therapies themselves can be a little bit more aggressive.
Right.
And when you can get just sort of this overall inflammatory response to some of these cancer therapies, these immunotherapies, they're good, but they don't necessarily discriminate. It's your immune system trying to attack the cancer, but sometimes it also attacks your lungs or your heart.
Right.
So again, if they're a later stage and they're just on these more extreme therapies, or let's say they have to have really high doses of anthracycline, which we know can cause heart failure, that can be really challenging because now we're dealing with something where you're at higher risk for heart issues as well as a higher risk for cancer-related death.
Right. Do people really recover from stage four?
So I'm not an oncologist, so I can't say what their experience is. Certainly, mortality rate is a lot higher at stage four than if you catch it earlier.
Right.
But as someone within cardio oncology, if that person is still walking, talking, and able to do some of their daily activities, I'll continue to follow them and continue to support them in
Right.
any way I can from a cardiac perspective. I don't
Right.
say, well, this person's stage four, so we're not going to do absolutely anything. If they're
Right.
stage four, walking, talking, and they have a heart attack, I'm still going to advocate for a heart cath.
Right.
Because we just don't know. And again, there's therapies coming out with these different companies. And so, we need to continue to still treat these patients as if they're stage one or as if they don't even have cancer.
Right. Hmm. What are the most common cardiovascular complications seen in cancer patients undergoing treatment?
Mm-hmm. So more than likely, you'll see arrhythmias. A lot of times, a good amount of time, you'll see sort of benign arrhythmias, just a fast, your heart rate just kind of racing.
Right.
And cancer increases your sympathetic activity. So you're going to have sometimes just a racing heart here and there, or when
Right.
you're getting an infusion of the cancer therapy. And that's benign. Your heart's not going to completely race and explode or anything like that.
Right.
But other arrhythmias, patients with cancer and then certain cancer therapies can increase people's risk of atrial fibrillation. So atrial fibrillation, is a very prevalent arrhythmia nationwide. The prevalence is approximately 25% lifetime risk for any of us to develop atrial fibrillation, and that risk is higher if you have cancer. And then if you're on certain cancer therapies, that can increase your risk for atrial fibrillation as well. So AFib can be challenging because it can be very fast. Sometimes it can be slow. Some medications may work for one person, some may not work for another. Some therapies like ablations, some patients may be good candidates, but some patients may not be a good candidate for an atrial fibrillation ablation. Everybody's phenotype with atrial fibrillation, because everybody has different comorbidities, is different.